So how do we do this? Well, the short answer, which you'll get if you ask any statistician or other practitioner, is that it really depends. It depends on the circumstances, the nature of the crisis. For example, the opioid crisis and COVID-19 are very different, although they are interacting now in ways that we have yet to understand. We need to figure out what the major problems are. Okay, well, clearly too many people are dying, but why are people dying? Why are too many people dying? That's a complex question. And when we ask a really broad question like that, it's unlikely that we're going to find a specific answer. So we need to reframe our thinking and ask, what can we do about it? What do we know that is actionable, for example? And to try and get at what we already know, we can, for example, search from the literature. What has been published already? What are people saying in surveys, and what are we seeing in the data? Can we fill in some of these critical knowledge gaps? And for that, we need to know which relevant data are available. And key part here is relevant. So we need to think about our questions, what we're trying to answer, where we're trying to get, and which data that are available might help us address those questions. Next slide. So as many of you may know, in 2016, the province had seen quite an alarming increase in the number of illicit drug-related deaths and declared a public health emergency for the opioid crisis on April 14th of 2016. There was a bit of a drop in 2019, which is encouraging to see, perhaps related to successes with harm reduction and promotion of naloxone and other measures. However, we know that it has gone back up again with the pandemic. So clearly this is a massive problem that is not going away, and we need to do something about it. A little bit more on the background of the opioid overdose crisis. In 2019, there were over 24,000 overdose ambulance calls, which is roughly 66 per day on average in BC alone. And in the Vancouver Coastal Health Region, 39% of all ambulance calls were for an overdose. That's from the BC Emergency Health Services. Last year, there were 1,716 British Columbians who died of an illicit drug overdose, which is approximately 5 per day on average. And this is compared to a little bit under 1,000 for COVID-19, or approximately 3 per day. So despite the fact that there's so much coverage in the press and the media related to COVID, overdose crisis has been and continues to be a worse problem for our society. And harm reduction, which is our official approach so far, has really helped and it's really saved a lot of lives. It's clearly not enough. For example, no one's fatally overdosed in a safe injection site. However, many people who are overdosing are not going to safe injection sites to use. They're using at home alone. And a big part of that, we believe, has to do with stigma. We have to work to counteract that stigma. And to do better, I think that we need to shift our responses from being reactive in doing harm reduction to proactive, focusing on prevention. And as Gabor Mate suggested in the last keynote talk, part of that involves intervening in early education, right? It needs to become part of mainstream education to teach people about the dangers of drugs a bit more effectively. To shift from reactive to proactive, we also need to use data. So for example, we may be interested in predicting overdose before it happens so we can tailor services to individuals who are at greatest risk. To do that, there are various types of data that could be relevant. So we have administrative data, which is the type of data that we'll be discussing a bit more in detail. This is data that's collected through service use or organizational operations. The advantage of that is it typically is quite comprehensive in that anyone who uses a service, and when you're talking about government services, nearly everyone uses services like the medical services plan. You capture a lot of data. That's the advantage. Disadvantage is that you don't necessarily get detailed information on specific questions of interest. So you might run an observational study and collect observational data using a method like a questionnaire or a test, or you might look at social media or web activity. We also can collect data through experiments via randomized controlled trials in humans and animal models. We can do qualitative work. There are great there's great examples of qualitative work being done at the BC Centre for Substance Use, for example, where they go out and interview individuals in the downtown east side and at homeless shelters. And we can get free text, high quality responses that way, but we can't collect a lot of data. We can also run simulations using computer models to evaluate scenarios before implementing a policy change, for example. So there's great examples of this for COVID, where they look at what happens if we implement different restrictions for social distancing and masking and all of that, and how do we expect that might change the rate of infections. The idea is that hopefully we'll be able to develop sufficiently realistic models to do something similar with opioid overdoses. Data science is a broad field that can help us answer these kinds of questions to address operational problems. The real challenge, however, is to gather data that are relevant to your research questions and apply appropriate analytical methods to it. And what is data science, for those of you who are new to it, the term? Data science is broadly considered to combine subject matter expertise, programming or hacking skills, and statistics or machine learning or mathematical knowledge. And this is a famous Venn diagram that some of you may have seen before by Drew and Conway. The idea is that we use these different techniques to varying degrees to generate actionable insights that can address business problems or health problems or policy problems. Really, it's just an expansion of traditional research into more automation and more sophisticated analytical methods. And I think it's helpful when we're trying to go about solving an issue like the opioid crisis to think about our goals, right? And there are three main approaches that we can go about this. We can conduct a descriptive analysis. So we may be interested, for example, to know how many overdoses there have been, where and when. To do this, we typically would use exploratory data analysis methods, or perhaps unsupervised machine learning, techniques like clustering and factor analysis. Another goal might be to explain. So why or how are people overdosing? How does factor X influence overdose rate, or whatever the other dependent measure is of interest? And this employs techniques like traditional statistical modeling, basic regression, hypothesis tests, and more recently, causal graphs. So we can develop causal hypotheses and theoretical models. We also conduct randomized controlled trials. And through this, we can identify risk factors and possible intervention points. A third goal, which Andy will cover in more detail later, is prediction. For example, we may want to know who is most likely to overdose, where and when. Can we get services, can we get that person the help that might benefit from before it's too late? So for this, we would use predictive modeling, which is often also called supervised machine learning. We can also forecast service demands and identify individuals who are likely to need help most urgently. Some of the tools at our disposal to dive in a little bit deeper to those other 3 points before. When we're describing data, we typically use exploratory data analysis, which means descriptive summary statistics and graphs. This is typically necessary for evaluating data quality and figuring out which models to try. You need to understand your data before you try modeling it, is the basic idea here. We can also answer some basic descriptive questions like how many overdoses have there been? And that's the sort of work that you see from the BC Coroner Service in their reports. I'm developing software also to make this easier in an R package called Elucidate that you're welcome to try out. It's free for everyone to use. In terms of statistical tests and models, these are things like t-test linear regression and extensions of linear regression models. They're useful for attempting to explain the data generation process. So where did these data come from? How did they end up showing the patterns that they're showing? We can test hypotheses. We can evaluate policies, interventions, and events, and we can do time series forecasting with these methods. They're ideal for problems of low to moderate scale or complexity, or when interpretability matters. Then we can move, if we have a more complicated problem, we can use complicated algorithmic models, which are also called machine learning. These fall under broad categories such as supervised machine learning, where you have an outcome past examples of an outcome that you can try to use to predict future examples based on other features. You use this methods like deep learning or artificial neural networks in random forests. And Andy will show you a couple examples of tree-based models that do that sort of thing later. can also use unsupervised learning, unsupervised machine learning, where the basic goal is to detect latent patterns in the data based on similarities across features. For example, cluster analysis. Are there subgroups within a population based on features of interest? This tends to scale quite a bit better than traditional statistics and shines when prediction is a top priority, where you can pick up on complex interactions more easily. So I think it's helpful to reframe the traditional data science Venn diagram by these goals. So rather than thinking about machine learning or traditional research, think about what your goal is, and then different skills and knowledge will overlap to varying degrees to help you achieve that goal. So we have, if we're using prediction, we're primarily depending upon hacking skills and some knowledge, some basic knowledge of statistics and the algorithms that are involved. But we don't need to know as much about substantive or subject matter that we're studying. Whereas to describe, we need to know about the subject that we're studying, and we need to do some programming. We need to know a little bit, but not very much about statistics. And to explain, we don't need to use very complicated algorithms, but we need to know to use methods that are well validated and are interpretable. All of those go together to help us understand the problem to varying degrees. And it's helpful to think of these things from different perspectives to get a comprehensive understanding. So for the rest of the talk, we'll be focusing as an example on work that Andy and I have been doing with the BC provincial overdose cohort, which has been collecting data or combining data from 2015 to 2018 so far, and we'll continue to add more data moving forward. This data set includes all individuals as cases who have had at least one overdose in BC since January 1st of 2015. Also includes a reference or control population, which is a 20% random sample of British Columbians who are registered in MSP, which we believe captures most of the population. Together, we end up through this process with over 800,000 individuals in total. It varies a little bit from year to year, but from about 810,000 to 846,000. The data in the overdose cohort are organized in 3 different ways: by overdose events, by individuals, and by healthcare episodes. There is, however, something to consider here, is that including all cases and only a 20% reference sample means that cases or individuals who have overdosed are 5 times overrepresented in the data. And we'll touch back on what that means in terms of interpreting results later. So on the right, you can see a diagram showing the different data sources that are used to gather information for the overdose cohort and how individuals end up in the cohort. So if you interact with emergency health services, for example, if you have a death record showing the cause of death being related to drug toxicity or drug overdose, if you come in through an ambulance, if you have a chronic disease or a mental illness, if you've been prescribed opiates, for example, if you end up in the correctional system or are on income assistance, then you can also end up in the cohort. And there is information on First Nations in the First Nations climb file, but only the First Nations Health Authority has access to that data to ensure that research is being done as respectfully as possible. So in my work, I'm trying to focus a little bit on population adjusted healthcare episodes to try and get at or counteract this sampling bias that we have to deal with. And when we look at population adjusted estimates, we have non-overdose health episodes on the left, in the left panel here. In the middle, we have non-fatal overdoses overall. And then on the right panel, we have fatal overdoses overall. And what we can see is that non-overdose health episodes have been relatively constant over the period. So health service utilization is not really changing overall that much, but overdoses are increasing quite a lot. There was a bit of a dip in 2018 in terms of non-fatal overdoses. And there's been an increase in fatal overdoses in the right panel that's kind of been stable. I mean, hopefully we'll see that drops a little bit in 2019, matching what the coroner's service has reported, but the data will tell us. Some of the questions that we may be interested in examining, for example, are how does poverty or income assistance dependence influence an individual's probability of overdosing? Another question could be, are individuals with a mood or anxiety disorder more likely to overdose, and by how much? Is incarceration or release from prison a greater risk factor for overdose? Now, I'd just like to spend, a few seconds here thinking about what do these questions imply and how could we go about addressing them? So if you think back to the different goals or the different methods that I covered earlier, are there any suggestions in terms of what you think would be appropriate for this, members of the audience?
Feel free to unmute or raise your hand if you guys have any hypotheses. Okay, I guess we can pick on people as well. Kimia, do you have any kind of comments for, I guess, the first question? How does poverty influence an individual's probability of overdosing?
I would hypothesize that it probably correlates with it positively. So I would say the more you experience poverty, the more you're likely to overdose.
That's a great hypothesis.
It is a great hypothesis. So how could we go about trying to examine that, do you think?
I would say we could use some of the data available. Like from what I've seen, like living in Vancouver, there are areas in downtown where you can make observations without like really intervening with the participants.
Okay.
Other than observing, we could probably stimulate those kind of environments, but I don't think that would really be, I don't know, unless like getting participants to like getting participants that are willing to participate in such study, so we can get data on their like income and everything, and then also do maybe like a longitudinal study to see how like over time the stuff that happens to them affects them. I don't know.
Yeah, no, these are great suggestions. And I mean, ethics are something to consider also when you're doing human research, right? So there are certain things that we wouldn't be able to do, but I'll show you what we have done with the cohort after relating to this. Does anyone else have thoughts about how we might examine likelihood of overdose for individuals with mood or anxiety disorders as a second point?
We can also pick on more individuals in the audience. Let's see. Kathy, do you have any kind of, I guess, hypotheses towards the second question?
Sorry, not off. Sorry, right off the top of my head. No.
So
no worries.
I guess for a yes or no answer, do you think that mood or anxiety disorders contribute to overdosing for individuals?
I would say probably yes.
Mm-hmm.
They might be on other medication as well for the mood or anxiety disorders. So there might be that sort of concurrent issues that they might have. I have no idea how much, but I would say that it's probably more likely, yeah.
Okay, great. And that's a great suggestion with respect to other medications people may be taking. So for example, Andy, you could look at the PharmaNet data, for example, and see if other medications people are taking affect whether or not they're overdosing. Well, we don't need to put too many people on the spot here. We can move forward.
Yeah, I think these questions are great to kind of stir up some thought. And of course, Craig is going to continue the presentation on what he's done. I think that was an accident.
So we began by looking at interaction with income assistance clients and overdose. And we started by looking at individual level estimates. So this is when someone overdoses, or of the people who have overdosed or not overdosed, were they an income assistance client or not? And I want to highlight here the numbers, the percentages that are highlighted in the red boxes, which is the proportion or the percentage of individuals in different health episode types or health episode categories that were income assistance clients. Oh, can you go back? Yeah. So what we see is that when we look at non-overdose related health encounters, only when we look at non-overdose related health encounters, we see only about 1% or 1 to 2% of individuals who had those health interactions that were not overdoses were income assistance clients. But then if we look at overdoses, it's much higher, it's almost half, which is quite surprising given that they make up such a small fraction of the overall population. And as a positive control, we looked at individuals who didn't have any kind of interaction with the healthcare system at all, and we see that that only makes up about less than 1% of the individuals in the cohort in the reference sample. So we believe that most of the individuals in the cohort are interacting with healthcare services to some extent, and we're capturing most of that data. Next, breaking it down by income assistance client status or non-client status, we see that the annual non-overdose health episodes have been about 2.3 to 2.5 times more common for income assistance clients, which are the red bars, than non-clients, which are the blue bars. Health episodes per capita or per person are also slightly higher for women than men on average. So that's about 1 to 2 extra encounters per year. And there doesn't appear to be any interaction with SDPR status. I suspect that this may be not because it's SDPR is social development and poverty reduction, is the ministry that individuals go to visit to get income assistance support. Sorry about that. You're welcome. So I suspect that this discrepancy between women and men has to do with the fact that women are more health conscious and then go to see the doctor when they need to more often than men do. But the data may show otherwise later, we'll see. When we look instead at overdoses, we can see a dramatic difference here where it's not just 2.3 to 2.5 times higher, but it's actually 50 times higher for income assistance clients than non-client residents. So for reference, we have about 4.4 to 8 episodes per 1,000 individuals for non-client residents versus 218 to 567 per 1,000 individuals that are SDPR clients. And this is across the province. So on the left side, we have overall the data combined together. And then on the right side in the right panel, I've split it by women and men. And we can see that there was a bit of a dip there for women. It's less noticeable for men from 2017 to 2018. But yes, so this is just telling us, shows us very starkly that the rate of overdose after you control for population is much higher in the income assistance population than the non-client population. We look at fatal overdoses, we see a similar discrepancy here, although it's even actually more noticeable. So what we're seeing on the right side, when we're looking at women, we see that fatal overdoses are 67 to 97 times more common among women SDPR clients than women non-client residents in blue, and 25 to 28 times more common among client men than non-client men, but they're higher for men overall. And that is consistent with what the coroner's service reported, where it seems like men are overdosing at much higher rates. However, we're seeing this interaction with poverty in that income assistance clients who are women are at a relatively much higher rate of overdose than women who are not clients. So that suggests to me that they may need some extra support if they're struggling financially in terms of mental health supports and other services. We also looked at individuals who had a mood or anxiety disorder in the same year. So these data look at when somebody comes in, they have an episode, if it's a non-overdose health encounter, if it's a non-fatal overdose, or if it's a fatal overdose, when that person came in and interacted with those services to receive support, did they have a diagnosis of a mood or anxiety disorder in the same year? And we find that the rate of this is alarmingly high. For income assistance clients, for general health problems other than overdose, it's a little over 90%. So most income assistance clients who are receiving or who have other health issues also had a mood or anxiety disorder. We see a discrepancy where that's a little bit less than half for non-client residents. And we still see this kind of difference between clients and non-clients when we look at non-fatal overdoses and fatal overdoses, although the magnitude of that difference is not quite as large. This is clearly showing, however, that mood or anxiety disorders are undertreated, especially in the poorest inhabitants of our province. We also looked at transition points for individuals who entered prison within the past 30 days or who were released from incarceration within the past 30 days. When we look in this graph is showing what happened when individuals were released or were incarcerated or put into prison in the past 30 days. We see that overdose rates are significantly higher, especially for income assistance clients. So we don't see very high rates of overdose among non-clients who were incarcerated recently. And hopefully that's because it's harder to access toxic drugs in prison, but we know that some are still getting in, right? So this is an area of concern. So we think that this suggests that incarceration may increase the stress of being incarcerated, and loss of freedom may increase risk of overdose. And then when we look at release from prison, we see that it's actually worse. So when people, and the thinking is that when people get used to being in prison, they don't have access to the same drugs, they lose their tolerance. And then when they leave prison, they're back in the same environment. They may try using the same dose that they had used before, and they overdose because they're not used to it anymore. Right? And we're seeing here that SDPR clients who overdosed or had a non-overdose health encounter, were more likely to have been recently released from prison than non-clients. And we think that this may contribute more substantially to overdose risk than being incarcerated in the first place. So just to summarize what I've covered so far, the BC Provincial Overdose Cohort is allowing us to examine health episodes for all individuals who experienced an overdose in BC after January 1st of 2015 and a 20% sample from the general population. About half or almost half of individuals who experience an overdose in BC are facing extreme poverty and rely upon income assistance. The incidence of overdose is at least 50 times higher for these poor individuals than non-client residents. And while men appear to be more likely to overdose than women overall, there seems to be a larger disparity in overdose rates between income assistance client women and non-client women, suggesting an interaction with poverty or income. Lastly, or finally, of the individuals who experienced a health encounter, most income assistance clients and many non-clients also suffer from a mood or anxiety disorder, and release from prison may be a greater risk factor for overdose than recent incarceration. Our next step in this project for my side of the work will be to do some explanatory modeling. So the prior descriptive results are preliminary and should be interpreted with caution. For example, we can't resolve confounding factors, influences of age and gender, and then controlling for that, whereas statistical modeling can. So I'm going to be applying hierarchical or mixed effects models to account for the longitudinal and repeated measures nature of the data, and that work is in progress. It lets us to, for example, ask how income assistance reliance, release from prison, history of mood or anxiety disorders, et cetera, impact the risk of overdose after adjusting for other information. After, for example, if I already know demographic information on someone, if they were homeless, what their substance use history was, does income assistance or poverty still matter, and how much does it matter? These regression models can help us develop an evidence-based theoretical understanding of the social determinants of overdose that can be used to generate testable hypotheses and recommend intervention points. With that, I'll take any questions that you may have as a little bit of break, and then Andy will continue on and discuss predictive modeling and what we can do with that, or what we've done with that so far.
Are there any questions? Feel free to unmute and ask them before I jump into predictive modeling.
It's Ann Livingston here. I find this prison stuff like very cloak and dagger, trying to get any information about prisons. But so there's a kind of understanding that if you're in prison, you become abstinent. But I'm thinking that people do get out in prison, and some don't. But then there's this weird gap when they get out. I don't know how you guys can uncover this. If there's not a smooth transition from your prison out to your community out, then you use street drugs while you're trying to get back into your out, or you're using street drugs because you're just celebrating getting out of jail. I don't know which, but anyway.
Yeah, that is definitely an issue, and there's certainly problems there where we need to improve coverage for treatment. Never mind the fact that there's even more stigma for individuals who have a substance use disorder and a history of incarceration that we need to counteract. The point is not to punish these individuals. The point is to try and help them, right? So we can work, we will be working with PSSG, which is the Public Safety and Solicitor General's Office, to try and get at more detailed information on incarceration history. But that work is going to take a little while, I think.
Also, I just wanted to warn you, I've been doing this since God, and there's 3 kinds of prisons, and I usually only thought there was federal and provincial. There's also city cells. And, you know, in the last year or 2, I came to understand that you could be held in city cells like in Burnaby. Who knew? And they can catch you on a Friday and keep you to a Monday. And then when you go to pick up your oat, your pharmacy won't give it to you because you've missed 3 days. And
Really?
Some huge punishment comes down on you for missing 3 days. You get 30 mils, which of course, so I'm not sure if you're getting data from jail, and it's any old jail, including city cells. So anyway, all these things are so nuanced. I don't want to make it more complicated, but I just wanted you to be aware of that. And then, are you just doing federal or provincial or both?
We are only able to access now provincial data, but that is very good to know. That I didn't realize that they could hold people for that long in city jails. So thank you for sharing.
Any other questions? Okay, why don't we keep the questions to the end of my presentation since time is running short. Is that okay with you, Craig?
Yeah, absolutely.
Cool. So next, I'll be talking a little bit about predictive modeling and what I've been doing in my lab in partnership with the CDC and alongside Craig. Thank you, Craig, first off, for that amazing presentation. I think it was very informative and ties very, very nicely to what I've been doing with the CDC data. So again, my name's Andy. And so first off, a couple of different questions that I'll be trying to address in this presentation include things like why use supervised machine learning when compared to traditional statistics? So what are the pros and cons of those two? What types of data gathered is useful for predictive modeling? Of course, we've seen the CDC data, but what are some benefits with using administrative data? What are some problems that I've been facing? And lastly, what are some variables we can hypothesize that are important? So this includes an example, a preliminary model that I've done, and we can discuss a little bit about those variables that the model has selected and see how that affects real world and what are the real world implications. So first off, machine learning can be split into 2 different types. Supervised machine learning, which utilizes past examples to basically predict a certain outcome. So for my instance, I'm trying to predict fatal overdose. So I'm utilizing the drug using population. It's a little different from what Craig has been doing, since he's utilizing the non-fatal overdose as something that he's trying to understand. but for my model, I'm only trying to predict on fatal overdose, as well as unsupervised machine learning, which basically detects latent patterns in the data based off of similarities across features. So as you can see in the right, that's a good example of unsupervised learning, where you're basically just classifying the data points into clusters, versus supervised learning, where you're trying to predict at a certain point. So again, we'll be focusing on supervised machine learning in my presentation. So machine learning is ideal to produce a diagnostic or risk tool to address individual problems that exist within the overdose crisis. There already exist tools such as the Orion Project E tool, which utilizes kind of a bar, and the model is based off of administrative data, where it's a different population, but it's basically addressing the same points, trying to deal with risky behaviors that the individual might do. And so something like that actually already exists. So machine learning tends to scale better than traditional statistics and shines on top when prediction is the top priority. It maximizes accuracy of prediction to have real world impact, and it's ideal to solve a very complex problem such as the overdose crisis with large amounts of data, such as the overdose cohort, which I'm using from the CDC. So in traditional statistics, one of the key roles is to describe the data and make inferences that can help you develop an understanding of the data. But for machine learning, you're trying to basically only predict an outcome variable. And as a result, I will present to you the golden rule of machine learning. Because we're trying to focus only on prediction, we split the data initially into two separate sets for training the model and also the testing the model. The testing data will then allow us to understand how well the model is performing at its predictions. The golden rule basically states that the model can't see the testing data's outcome variables prior to the completion of the training of the model. After the model is created, we then feed the model with the testing data and compare the model's predictions with the true outcomes that we already know from the data. So what are some tools that you see today that utilize machine learning? This is the part where I'm asking for some participation. This should be quite simple, quite easy, daily tools that you might see. Actually, maybe it is a little bit complicated, but
maybe even on your favorite electronic devices.
Yeah, that's a great hint. Okay, I will. Okay, so I can just kind of answer that for the audience. So things like Google, Facebook, YouTube, Yahoo, these different search engines utilize machine learning to target the audience based off of what they're clicking, as well as things like Tesla, utilizing automated driving to basically identify certain objects, to understand what to avoid, and a pattern recognition kind of thing. So next, we'll jump into the utilization of the CDC data. So as Craig has previously mentioned, we've partnered with the British Columbia Center for Disease Control to utilize the overdose cohort to elucidate risk factors associated with overdose events. As you can see in this diagram, data has been collected by the BC CDC since 2016 from different local health authorities. One key feature of the pyramid is that we're utilizing data that only includes recorded overdose. As you can see in the bottom, all drugs related to overdoses in BC, there's data that basically slips out of the CDC hand if they don't touch local health authorities. And as a result, this is a limitation that we'll talk in the future. So as a preliminary model, I've utilized data from the BC Coroner Service, ambulance reports, Drug and Poison Information Center, as well as chronic disease registries to find these specific features or data points that I hypothesized to be related to fatal drug overdose. And as a starting point, my colleagues at the ACD group had identified through a literature search and expert opinion survey key risk factors that contribute to drug overdose. When comparing to risk factors from the CDC, as you saw prior, this Venn diagram shows the risk factors that are similar between both overdose cohort as well as the risk factors that were chosen by the ACD group. As you can see in the middle, these risk factors can be seen in both. Utilizing the data sets previously mentioned from 2 slides prior, here are some risk factors that I've included in our preliminary model from these different health authorities. And for my preliminary model, I have used tree-based models such as XGBoost as well as Random Forest. This slide shows what an example of what a tree-based model is. As you can see, it's a classification model. You can basically, as you can see here, each section here is a tree, and basically each tree classifies individuals based off of the specific feature that is involved with. And you can add each of these trees to classify different features that might affect the decision of the model to classify an individual to have had a fatal overdose. When you combine a bunch of these trees together, you build a model called a random forest. So these, based off of the features that we've selected, as you saw in two slides prior, these are some preliminary test results. So again, this is very different from statistics, traditional statistics. We're looking at things like accuracy, which basically means the number of correct assessments divided by the number of all assessments. Sensitivity, which is basically the correctly predicting individuals that are fatally overdosing within the fatally overdosed. Specificity, which is correctly predicting individuals that are non-fatally overdosing within the non-fatally overdosed, as well as area under reciprocating operating characteristic, which basically tells that's a measurement of whether or not the model is discriminating between cases properly, and it's a 0 to 1 evaluation. And again, XGBoost and Random Forest are both classification tree-based models that I've talked about briefly before. So here comes some interesting results. I present to you the most important risk factors contributing to the XGBoost model when predicting fatal overdose. And then, as you can see here, our results are in line with the current literature on risk factors that are involved with overdosing, as it makes sense that opioid consumption as well as other substance use behavior are highly associated with overdose deaths. And some other key risk factors include overdose frequency and also being divorced. And so these are obviously maybe some features that aren't explored in depth within the current literature that are interesting results. And here are some more important risk factors associated with fatal overdose chosen by the Baruta and Random Forest algorithm, which is different from the XGBoost algorithm. And it is, again, safe to say that these different features that are being selected make sense, as though these drug substance use features are the top features that are related to fatal drug overdose. And again, there's the divorce feature there, and also another interesting one is tramadol, which is prescription opioid use. So a key thing to note is that although it's the same data, different models will choose different features, which is quite interesting as a result. And in addition to that, although we know that these risk factors are important, as a preliminary result, the model won't tell you if it's a protective or risk factor. So you have to do additional data analysis to figure that out in terms of the side that the feature is important, or why it's important. So as I previously stated, some of the data I've been utilizing include data from different sources. And so as a result, my question to the audience is, what kind of data do you believe is more or less precise? Okay, I will pick on somebody. Rachel, what do you hypothesize as, data points that are maybe, could be flawed or could be, more or less precise?
I apologize. I actually just got pulled into an urgent thing I'm working on at the same time. So unfortunately, haven't been paying as close attention as I would like to. I apologize for that.
Oh, it's okay. Do you want me to reiterate the question?
I don't have the context of the previous slide is the issue.
Oh, sure. So
Yeah.
basically, I've created this model with different data sets from the BC CDC, and basically the different data sets. So I can go back a couple slides. So as you can see here, I've utilized the ambulance calls data set, the BC Coroner Service, chronic disease registries, and drug and poison control. Just from this, basically, so I'm basically utilizing a data set that has that's describing the drug using population and trying to predict fatal overdose. Just as a first glance, do you see anything maybe that could be wrong with this data set? So obviously, maybe looking at BC Coroner Service, when comparing that to control, the different local health authorities will have different variables that they're collecting, right? So maybe, yeah, do you think there's other data sets that I can be using that can be more standardized and more precise?
I mean, without the BC context, I don't know exactly the other administrative data you collect, like your health records and how cross-shareable those are. But, you know, presentations within emergency departments and those sorts of things, as well as additional services that the individuals may access. I don't know how shareable that is across your data set, though.
Yeah, so I think that's a great answer. So for my second attempt, I basically proposed the utilization of ICD-9 and ICD-10 codes, which exists in the CDC overdose cohort as the medical service plan and discharge abstract database, which is basically administrative data, as Rachel has said. This is more universal. And basically what I'm proposing is for my derived variables list that I'll be creating, I'll be screening for both MSP or DAD for either 2 medical visits or 1 hospitalization visit to represent these codes, to present a specific feature for an individual. So for example, if an individual has gone to the hospital for a neurocognitive disorder, then the derived variable would be a 1. So it'd be a binary variable. So it'd be a lot more standardized because it covers the bulk population instead of something like coroner service that only is selecting the individuals that have passed away. So as a result, these are the new categories or new data sets that I'll be creating my derived variables from. And lastly, I'll be talking about a little bit about the limitations of machine learning as well as data sets. And Craig, feel free to jump in to this part as you please. So
Andy, with respect to the last slide, are you going to be adding that information to what you're already considering, or will that be a separate model?
So this will be a separate model. Okay. This will be a separate model because is this a question from the audience?
No.
Oh, okay. I will also talk a little bit about the class unbalance, which again is one of the key problems that I've had with my preliminary model. So a limitation to the individuals, the data is basically limited to individuals who have only touched the healthcare services in BC, as I've previously stated with that pyramid diagram that I showed everyone. Healthy individuals that aren't overdosing or using are underrepresented, even though these individuals might be at the most risk when they're using the drug supply that has fentanyl in it. Data collected from different sources can vary in quantity and format, which is basically one of the first problems that I've had with my preliminary model. And passively collected data sets were not specifically collected for the use of machine learning. So a lot of the times these variables have to be adjusted and played with. And lastly, missing data, which isn't that much of a problem for administrative data, as that's actually one of the strengths, because administrative data should be, well collected and shouldn't have many missing variables within it. Anything else to add, Craig?
Well, I would just, reiterate that the sampling is perhaps the greatest issue. Sampling bias, where you have, healthy individuals being underrepresented, is perhaps the greatest limitation of this particular data set.
Yeah, definitely. So one of the key problems with my preliminary model is that because the data was collected from different sources, I know I've beaten this point to death, but I've utilized sampling for the non-cases or negative examples to balance the sample out. Actually, the sample that the final data set I got was around 400 to 500 individuals that had taken drugs but not fatally overdosed, compared to 4,000 from the coroner service. And again, this is a representation of real world a real world example where individuals that are overdosing in around BC, downtown East Side, or in rural neighborhoods, they call for an ambulance and the ambulance comes and records it, but there aren't many characteristics about that individual's pattern of drug use or different risk factors that are collected from local health authorities, because these individuals get naloxone, or if they're overdosing, they get naloxone and they just basically stand up and refuse to go to ambulances or hospitals because of the stigma in the province, and therefore there is no recorded data on this population. So finally, I'll touch upon some limitations to machine learning. So the model can draw conclusions that amplify stereotypes from cognitive biases of data. So as a result of this, this is really important to develop these algorithms or these models alongside experts within the field, as well as co-develop it with people with lived experiences. Another limitation is that it needs large amounts of data. It has limited interpretability because all it focuses on is the predictive value, and therefore associations and correlation. It's basically a web map of that, so it's very hard to interpret. If data is not representative, then results are of limited use, as these predicted variables that are important for the outcome variable, if we don't understand what these variables are, then we can't do anything about the behavior. Poor knowledge translation and reusability of models and integration. And of course, maybe one of the questions that the audience has about the Orion product is if there's something that exists out there for that I've touched upon, like a predictive tool for overdose, fatal overdose, then why am I doing it again, right? And the biggest thing is that after I create this model, it only applies to that population that I've gathered data for, I've utilized data for. And lastly, they encode correlation and association and not causation or ontological relationships between the variables. And that concludes my presentation. Are there any questions for me or for Craig?
Sorry, David Hutton talking here. Just wondering what, most of my work is with youth and children, and I'm just wondering, especially in the teenage bracket in that population, do you guys have, from your, so far and what you've looked at, enough data to speak to that population within a client service sector, or is that something you're still looking for more information on?
Well, I can take this one. David, it's been rather difficult to study youth, unfortunately, with the data that we have. A lot of the services that people are interacting with, where we're collecting that information, are individuals who are over the age of 19. However, there are other projects in, for example, the Data Innovation Program, which is a separate information sharing platform across ministries, where we are able to access some information on youth, so we can try to get at that. Where that data set is a little bit more representative, in that it includes people from across the province, and rather than a 20% sample of healthy individuals. So we are working on it, but it will take time.
Thank you.
Welcome.
Are there any other questions? I'm actually going to stop sharing so I can see chat. Okay, cool. I'm also going to check Huba really quickly here. No, we have no questions from Huba as well.
Okay. Well, feel free to reach out to us later on the Huba platform.
Yeah, definitely. And we have the slides posted as well as additional information on the Huba website for our
for the workshop event.
For the workshop, yeah, actually, it wasn't even Okay, great. Yeah.
Thank everyone for coming and spending your time with us.
Yeah.
And we
thank
hope
you.
that you've learned a little bit and that take something useful away from this. All right.
Okay, thank you everyone. And just as a heads up, the next part will be the block 3, which is addressing the opioid crisis, the system perspective at 1:10.
Great.
Okay, bye everyone.
Talk to you later. Bye.